Hi there, this is Dr. Paul Singh describing an iStent inject video, in fact discussing some of the pearls I've learned after my first few cases. Here we are after the lens was implanted into the capsular bag, injecting viscoelastic to deepen the anterior chamber. And with these inject cases, I'm not as afraid to really overfill the AC to get a nice deep chamber. Putting viscoelastic on the cornea now, and then tilting the head and the scope around 25 to 30 degrees. It may depend on your view and with the actual positioning of the eye, but around 25 to 30 degrees with the gonio prism on the cornea. I use the eye prism, which gives a nice wide view, and then zooming in to get a nice view of the entire angle. Now, entering the eye with the iStent inject, you have the protective sleeve advanced, and then once you're past the pupillary border, you can retract the sleeve to expose the trocar. And we want to engage the trabecular meshwork in a perpendicular fashion so we prevent from trocar bias. Applying pressure posteriorly to achieve that dimpling effect. Pressing the button on the loader to release the stent, but holding it in place for about a second or two, and then retracting back. And then I tap it a few times to confirm that the stent is in proper position. Now I move to the other side, but I see the iris bowing forward where near the pupil, and the chamber is flattening. So I take my time, come out of the eye if I need to, inject some more viscoelastic in the anterior chamber here, and then also some viscoelastic on the cornea. The view is 100% the key issue with any of these MIGS devices. Once you have a good view, things are much easier. So I go back in the eye with the sleeve advanced, retract the sleeve to expose the trocar, again, more towards the left side of my wound now, for my second stent, apply some dimpling, some pressure posteriorly, and then advance and press the button. I didn't dimple quite as much in this second stent, and so therefore it wasn't quite seated into the Schlemm's canal. Using my edge of my loader here, I can go ahead and just tap it further in to Schlemm's canal. It looks beautifully seated there nicely. And that can be a nice trick to use the loader to help push it further in if it's not quite seated in the Schlemm's canal. Now that I felt comfortable with both stents, I can kind of confirm they're both in good position. You see a small reflux of blood. And in fact, we can also see a little higher magnification here, showing some reflux of blood and showing these stents are in good position through trabecular meshwork in Schlemm's canal, approximately 2 clock hours apart, which is the idea. Here we are now removing our viscoelastic like in any other cataract surgery. And just like routine cataract surgery, you want to hydrate the wounds, confirm the pressure at the end of the case, and the patient's hopefully doing very well. Thank you so much for watching the video.